Welcome to Mic'd Up with ChiroUp. Today's podcast, I want to cover two topics. One's going to be clinical, and the other one's going to be clinical efficiency. And the first one really is sparked by an email I got from a subscriber, and I'll talk about him towards the end of that clinical topic. And the second is going to go over some new functionality that I am very, very excited about. In fact, I've been using for about 4 months now, and realistically, I can't imagine doing a note without it. Dr. Burrows and myself have been hinting at this functionality for a while. We have had 7 beta clinics have done their due diligence, their testing, their commenting, their criticism, and realistically, now it is done. I look at it as really the future of chiropractic documentation, kind of that one button and done mentality. So I hope you'll stick around for that piece of it. Just as a reminder, if you haven't yet, hit the follow button, share this episode with a friend. It does help us creep up the rankings as far as chiropractic podcast, and really just share good information with fellow chiropractors like yourself. So first off, a case that I still is unfortunate, but it's kind of one of those situations where you see a patient and you haven't seen that presentation in a while. And it's when you're not confident how to proceed with the patient presentation because like yourself, I'm in full-time practice. Dr. Bertelsmann is in full-time practice. We see a wide range of musculoskeletal injuries. And if you do this, you're sure to get this feeling every once in a while. And it's one of those signs and symptoms, one of those subjective and objectives that you get done and you're like, listen, I think you're fine, but let's go ahead and take some images. And I had this patient, was a 14-year-old, had an AC joint injury, literally hit a steel pole while doing a football a route. He's a receiver. And realistically, I thought he was fine. And I was like, you know what though? 14-year-old hit a steel pole. Let's go and take some images, make sure nothing was broke. And this is one of those situations where you get the images and it's not broke, which is great. I mean, really the only break that I'll still see in practice is a compression fracture of the spine, still something we can treat conservatively. However, for this one, I was like, well, we have a little bit of inferior displacement, a little bit of AC joint separation compared to the good side. We did both sides on the imaging. And I was like, what do I do now? So, of course, I dropped in the condition reference section of ChiroUp. I went to the management section to look at the different classifications that we'll see with AC joint injuries and sprains and breaks, because I wanted to know, does this person require surgery? Or does this person require rest? Or do they need something else? And, just as a review, when you're looking in ChiroUp in the condition reference section, we do have 2 diplomate level or DAC bars who are chiropractic trained, who do look at all of our imaging, look at the standards behind what images to order, whether it's a true imaging or ultrasound or blood test, whatever the diagnosis may be, to kind of give you a good idea of what we can manage in office. And then, of course, what should be reserved for another profession. So when I looked at an AC joint separation, we have a Rockwood classification, grade 1 through 4, and really the 1 and 2s are stuff that we can do in office. And this is our partial sprains. You might have a little bit of separation of the AC joint, but really this is just ligaments. There's no fracture. There's no significant displacement. When you have those kind of cases, this is conservative only. I mean, they're not even a candidate for anything else. However, what I'm concerned about with this case and other cases is when should I consider something else? And as it turns out, with a type 3 AC joint injury, when you can have rupture of the AC joint and the ligaments that surround that joint, and there is displacement. Now, upon digging into the research and digging into ChiroUp, this is still a conservative type diagnosis. We really should consider surgery only if there's significant deformity, if there's persistent pain, or really functional impairment after this thing should have healed. So in our high demand athletes, which are going to be using their shoulder and the shoulder girdle a lot, or overhead athletes, something we want to be really astute at making sure we protect those people in the long run. Now, if we do see someone in that grade 4 region, this is when we actually have rupture of ligaments. And since we do have rupture of those ligaments, we're seeing posterior, or superior or even inferior displacement of the clavicle, meaning those bones literally are not lining up anymore. That's when we are going to go in and refer them to a surgical option. It doesn't mean they have to have surgery. In fact, my neighbor fell off her bike and displaced her AC joint, full 100% inferior displacement, and they still didn't do surgery. In fact, it was considered cosmetic, not medically necessary. So it really does depend on the patient and the situation. Usually something that we're going to have an orthopedist evaluate in that situation. So just something to think about. And I love these kind of diagnoses, meaning I don't want to see a patient come into my office with a separated shoulder. However, it's always nice to match symptoms and the signs with the imaging. I mean, I think patients think it's, some kind of magic trick that we do. And I always think about like this one situation that we have with all of our patients. I shouldn't say all, but the vast majority of our patients coming in with neck pain, coming in with back pain. And when you really look at the research, anybody in their 50s, 80 to 85% of them have lumbar spine disc degeneration. And of those, 60 to 70% of those have it specifically at L5S1. If they're above 60, 90% of people have some sort of lumbar spine disc degeneration, and 70 to 80% of them have it at L5S1. So when a patient comes in, if you look at those numbers, roughly 65 to 75% of people over the age of 50 have degenerative changes. And of those, it's at L5. So we have to look at the statistics. We have to look at what we're dealing with. We have to look at the patient demographic. And if we can do that, we can match all those things. Our patients coming in think that we have some kind of magic trick of looking at that, but we're just playing the numbers and then matching those signs, symptoms, and images together. Now, just as the case in the shoulder and in the back, imaging is important. Degeneration is important, but often that's not the source of pain, and especially in the case of the spine, is that takes years to form whenever there's degeneration. But in the case of the shoulder, we really want to make sure we know what to do with this. Now, I want to give you a couple tips, because this is what I did with this patient that came in, is that when you can find a couple clinical features, we have to understand why it matters. So in the case of the shoulder, if you do see a step-off deformity, meaning you put your hand in the clavicle and you drop into the coracoid and there's a step-off, that's when it's going to indicate a significant displacement. So of course, we want to go follow up with some images. If you are seeing persistent pain despite rest, so typical ear ligaments, 3 weeks, 4 weeks, we should start to see some kind of linear decrease in pain. We have seen really varying degrees of advice on a sling. Historically, we put people in a sling. Now I'm seeing a lot of research say don't put people in a sling. But with that being said, if they go a month and it's not healing properly, unfortunately, that persistent pain does suggest instability or poor healing. Another reason to take imaging. Also, inability to elevate the arm above shoulder level, so about 90 degrees of shoulder flexion, or any kind of loss of strength indicates functional limitation. Once again, a reason we should be doing some imaging. But something else to think about. These last two were important to me, so I want to relay those to you. Is it painful crepitus? Because whenever you're getting painful crepitus, you're getting some kind of catching within that joint that really can lead that person into some kind of impingement that is caused by displacement. And the patient that I had, he did have some posterior displacement, which is going to essentially set him up for shoulder anterior impingement syndrome in the future if it's not surgically corrected. And also in the case of my patient, this is an overhead athlete. This is someone who's going to be using his arm on a regular basis, and he may benefit from early surgical destabilization. So at the end, he did not have to go through those things, but we did send him over to an ortho just to make sure that doing conservative measures was the best route for this patient. So just some things that I wanted to bring up. Now, my patient didn't have any significant, concerns or a significant posterior displacement, but I just want to make sure that I'm protecting him in the future. Now, I brought this up because those levels of insecurity concerning a diagnosis, something that, obviously as you go further along in practice, you'll have less of those moments. However, I got an awesome email from a subscriber of ours named Blake Hoover. He's out of Ohio, and he was talking about one thing that really kind of sparked this conversation. He talked about having a patient with persistent foot pain, and he was doing the most evidence-based, effective things for this patient with plantar fasciitis, soft tissue, extracorporeal shockwave therapy. He's roughing up the tissue, he's doing eccentric exercises. However, the patient was not getting relief of pain. But then, upon digging into his own evaluation, he found that the patient actually had a little bit different of a diagnosis, and it was a nerve injury. And then when he started treating that with the appropriate measures, the patient responded quickly and favorably. So at the end, if you are ever questioning your treatment because the patient's not getting the results that you expect with, check the diagnosis first. And then take a look at that diagnosis, find the most evidence-based way of treating it, whether it's through a mentor, whether it's through ChiroUp, whether it's through a friend, but find that treatment plan because getting the diagnosis is where it's at. That's where evidence-based chiropractors really exceed the expectations of the medical system and the patients because we care and we're going to dig in and we're going to be curious and find that diagnosis. Once you have the diagnosis, treating it becomes very simple. So now back to the beginning of the podcast. I said the future of chiropractic documentation is one button and done. Well, that doesn't exist. However, I do have a solution that does only require one button and done, and it does solve the biggest time suck in your day, which is listening to patients, recording everything they say, typing it all out, making sure you have a clear understanding of what's going on with that patient. I mean, when you really think about it, how much time are you wasting daily on actually getting all that information into your note? And what we did at ChiroUp is we did a survey, and it turns out across our survey demographic, which is ChiroUp subscribers, which practice probably in a way similar to yourself, the average provider spends between 5 and 12 minutes on an initial note, which adds up to literally hours per week. And the average interim note, so not a new patient, not a re-exam, but a typical note, takes between 1 minute and 5 minutes. And I realize everyone is different. However, let's even look at that. I was pretty quick, so I did everything with the dictaphone. I had a microphone essentially. And between 3 and 5 minutes for an initial note, and I was moving. I mean, I was using macros. I'm talking fast. And really talking as fast as possible. I'm not even quite sure how my transcriptionist could understand me. However, if I had to actually type all that stuff into an EHR, I mean, I'd be working at Lowe's by now. I'm still a 2-finger typer with my index fingers. Sometimes I'll get a little crazy and use my thumb or my pinky finger, but really, just the index fingers for Brandon. And really, this is something that, one, takes a lot of time and money to pay a transcriptionist. Also, I'm sitting in my car, I'm sitting on family vacations, I'm sitting at lunch at Chipotle, talking to myself on this dictaphone. And then 48 hours later, it would be, obviously my transcriptionist would get this back into my SOAP note. And one thing that many people don't think about when they use that kind of system, which is very fast, is the cost of that transcriptionist, which is significant dollars. And then I have people who use macros for everyone and everything and every situation. And really, when we built the ChiroUp system, I really wanted to build the system, and we have, without the need for salting, without the need for macros. It doesn't mean we don't have them. It just means that you really don't need them. And actually, you're not going to save any time using those. So really, the subjective portion, though, we can't salt. We really can't use macros for the vast majority of those. So I want to describe to you how we are using one button to start, one button to finish, and to really develop a way to get that subjective information into your note faster, more accurate, and 100% compliant. And if it sounds too good to be true, I can tell you with a team of chiropractors on staff here, with 6 full-time developers, I can tell you those things did come true. It is up, it is running. Now, the one thing that I did hear from our beta group, and believe me, we're still working on this. However, I'm not sure of the solution quite yet, and it doesn't mean that it's not going to get done. It just means it's not done yet, is that we have tried multiple ways and have tried getting the full SOAP note. It just doesn't turn out that well. I had to talk the entire encounter. The patient's in the room and I'm describing the test that I'm using. I'm describing the muscles I'm using soft tissue for. And then one of the biggest hangups with that is that at least for myself, when I'm treating a patient, I've got their subjective information from last visit, and I've got also my prior subjective survey that I use, so I can kind of tell, are they doing better? Are they doing their exercises? So when I'm seeing this subjective pull up, I can ask them questions and I can, use the voice AI. However, if you try to do the full SOAP note using voice, I need to have the right codes for billing and diagnosis pointing. I need to know what orthopedic tests were positive last time. You just can't get that very well on one screen. So while voice AI is up and running and it's going to be in your system as of next week, this is not something that can be used, at least right now, for the OAP. When I really think about the problems it does solve is that my documentation burnout, my spending late nights, weekends charting is gone. My thought process and my understanding of risk and compliance issues is gone. I'm going to tell you how we solve that problem. And it's not through rushing our notes or using macros. It's through actually listening to the patients and getting that information into my note. And then really the number one thing for me as a provider is the patients get more face time, because I'm not typing in front of them. I'm not trying to get my note done during that office visit. My subjective is done and more accurate now than it really ever has been. So let me give you the flow. Let me tell you what's about to happen in the EHR. I keep on talking about this one button, and I want to bring up one cool piece of this is that when you get that encounter, Johnny walks in the door and I hit that button, well, a couple things need to happen. You can't just record an office visit in ChatGPT. That's not legal, and it crosses a lot of different lines, let's just say. However, when I hit this button, the first time that I see that patient, I actually get an automated consent to record pop up on my screen, and I have to acknowledge that. It even gives me a script that I can use to talk to the patient about what this is, why it goes away. As soon as that happens, now that consent actually gets documented in that patient's chart. So that's kind of cool. And then, of course, you don't see that again for the next time you hit the voice AI button. However, when I hit that button, it's going to start recording. And the cool part about this is it actually recognizes all the different people in the room. So when you go and look at the transcription, you can see, person number 1, person number 2, and doctor, and it can differentiate who's actually talking. And I can tell you at the very beginning, without the proper prompt or without the proper prompt engineering that we've used for the last several months to create this, it can confuse you and the patient or two people talking in the same room. So if you start talking about, oh, you had plantar fasciitis, well, I had plantar fasciitis and it hurt when I, walked up mountains, we don't want that to get confused as what the patient is saying. However, once this happens, we get the whole voice recording, and it transcribes this. Now, that transcript is deleted once the note is created and signed, and we do that for security reasons and also for storage reasons. This is actually the best legal way to do it. Protects you and the patient and the software by not forcing the software to hold all those audio transcripts. Now, this transcript is going to be sent via a secure portal. All the agreements have been in place. It's secured at rest as far as ChatGPT and in transit to go to ChatGPT to come back as an actual summary of that experience. So the cool part is that now when you go to your subjective, you're going to be able to listen to all what the patients say. Usually, for me, to be honest with you, a new patient visit, it's going to be running for maybe 2 minutes, 3 minutes while I'm listening to the patients, and it goes through all my questions. For those re-exams or for interim visits, probably only about a minute of conversation before I turn that back off. All the fluff is filtered out about what they did over the weekend. And then within about 5 to 30 seconds, it is transcribed and it's actually put right back into my note. For when I sign that note, it actually has all that information in there. Now, if you pause it, you hit the button and it says, oh, I'm done listening, and then you want to resume, you can just hit the same button again. It starts the conversation up again, and it'll merge these conversations. And then, of course, at the very end, you can edit things. I would say in the last month, I've edited maybe one note. And I'll talk about these at the very end, but usually it's names, people, the spelling of a name or who are you referring a provider to. Now, let me explain to you a couple things. Let me explain to you the 3 reasons why this is different. So recording a patient encounter requires more than just a microphone. So some people are like, well, I can just put this into ChatGPT and it doesn't cost anything. Well, no. Well, yes, it doesn't cost anything, but no, that's not legal. One, you have to get consent. So that's the first piece. So in most jurisdictions, when you're recording audio, you need two-party consent. You need to explicitly tell the patient that you are going to be recording this, because for HIPAA requirements, any recordings containing PHI must be secured. Now, if the raw audio is stored, it is now part of that patient's record. So don't store the audio for very long or ever, because this is actually going to be needed as long as you keep that record, and that could be costly. So best practice is actually to play the automated consent script, like I said, making sure you tell a patient what's going on and that you're going to be recording the visit for documentation purposes. Make sure they consent. Document that patient's verbal consent. Put it in their chart. We do this once again. The first time you hit that button, it's going to be in their document. And then with a click of a button, it starts up that patient audio. You don't need to switch pages. You don't need to get out of the app. It really is very easy to use, and you never have to leave that screen. Now, the second part why this is different is that we're going to transcribe the findings. So the transcript is actually considered PHI when the patient's identity or any kind of complaint is included in that. Now, it has to be transmitted both at rest and in transit to ChatGPT in a very secure way, which we have, and accessible only to the authorized personnel, so only to providers who are logged in and starting that encounter, which is also what we have. Now, here's some important pieces, is that once you sign that SOAP note, we delete the transcript, which reduces your long-term data liability. This is a big piece of it that a lot of people don't do. And then also the summary that goes back into the SOAP note now becomes a permanent part of the medical record, not the raw transcript. And of course, if you have to review, you have to edit, you can do that before you sign it. However, this is one of these things, because sometimes when you take AI generated content, it can generate, other things. This is generative language. So make sure you read that to make sure that everything is good. And then go ahead and sign that note, and then that transcript goes away. Now, legal risk points is the third piece that chiropractors should avoid. Don't keep raw transcripts. Don't keep the recordings, because you actually have to have patient consent to do those. Second, don't use AI vendors that are not HIPAA compliant. Don't just use a random one that you found on the internet. You cannot do this. It is not legal. And then I want to give you a couple little pieces. And this is stuff that I've just learned, is that one of the things that I've seen is that with AI notes is that names often get confused. So you are responsible for the accuracy of the note. So making sure that before you sign that note, anything that was generated via AI, I know that myself, Dr. Bertelsmann, I practice with him. I can send patients to him. AI very rarely spells his name correctly. We work with vendors practicing for our billing. ChiroUp, ChiroUp, NCMIC, making sure that the names come out correctly. Because if you refer to an orthopedist and you have their name wrong, well, that's not accurate. So you want to make sure you double check those things. So I would say proper names are something that AI, unfortunately, just tends to not get right every single time. So some information on this. So affordability. One, we give you 100 minutes for free. Give it a try. See if it works for you. I've not had a person say it doesn't work for them. In fact, it saves them a ton of time. And then after that 100 minutes, we have a package that people can use. So we have seen that about one provider takes about 1,500 minutes, and that does unfortunately cost the ChiroUp money. I mean, it's a usage type service. That service is $49. It covers your entire clinic, and hopefully you can get all that done. And then after that, it's just pay as you go, as far as per minute. Setup is very, very simple. So I bought a $15 USB mic directly off Amazon. So you can use whatever kind of mic you want, but I have one that just attaches to my monitor. I use a touch screen for everything. It makes things so fast. And the touch screens that I use, I just have a Dell one. It has a USB on the side. and it's very easy to hook up. And then my screen is right in front of my patient, so I don't have any issues. Also, this service can be used for different languages. So if you have someone who's speaking a different language, they can talk into in Spanish. The transcript comes back in English, which is pretty sweet for that population. But if you have a mic, you have internet, and a subscription to ChiroUp, you can get started. We are constantly looking to improve this model, but man, it's pretty dialed in right now as far as the model in ChatGPT, the service, the cost effectiveness, the accuracy. So pretty excited for this. I think this is something that we can all use because you and I both know. I mean, our documentation as chiropractors is limited just because we're trading time for money. And it's a difficult thing to take the best possible note. And we're all going to cut corners, but we're going to cut corners in a legal and better way by having this one button way to get that subjective information. And really, if you look at it, incomplete notes are a top trigger for insurance denials and legal exposure. So we want to make sure that we have the most proper note that has all the information and making obviously sure this is HIPAA compliant. Now, one of the most interesting things that I heard from our beta group is, well, you guys already have this sweet survey system. Yeah, I still use it. In fact, it's really nice when a new patient comes in and I have the objective survey, the chief complaint survey that has when it started and how it happened and what hurts. Because in that conversation, they're going to give you that qualifying statement. Well, it hurt because I was playing baseball with my nephew, or it hurt when I was walking up a hill and I fell on my hip. Those are all things that unfortunately weren't compiled in the survey, and now the voice AI is going to pick that back up. So something pretty neat for you subscribers out there. And then next week, you're going to have it. It's going to be on your encounter section. We haven't found a better option. We're always looking for better options for our subscribers. It's fast, it's secure, it's affordable, and really frees you to do what you love, treating patients, and not worrying about typing things in your notes when the day is done. That kind of closes things up for this podcast. I really hope you enjoyed the clinical aspect of it and then also the functionality aspect of it. And then finally, I'll kind of give you the plea that I gave you at the very beginning. If you want more content like this and like the chiropractor that I talked about, leaving reviews, reading our blogs, the webinars, looking at all the other resources that we have on our site is important for you. But make sure that if there's something that we're missing or something you want to hear about in any one of those platforms, let us know. My email is Brandon, BRANDON, @chiroup.com. You can always email support@chiroup.com if there's anything going on. And we'd love to hear from you. That is where our company was built from. Tim and I thought we had some really good ideas on how to create ChiroUp, and we created it. However, everything past 2015 has been on the backs of your feedback. So please give us that information. We're looking to make it easier for you to practice and hopefully change the perception of where chiropractic is and where it's going. And with this podcast, hopefully we can all have some better notes, taking less of your time on a daily basis. Thanks for listening.